Are you sharing? Okay.
Uh, is it visible, sir?
Yeah, yeah, it's visible.
Okay.
Can you start the presentation?
Hmm. Uh, just one minute. Yes.
Mm. Yeah. Okay. Thank you. Good evening, everyone. Myself, Dr. Aslam. I'm a practicing dermatologist. Currently, I'm practicing in Guwahati, and I'm happy to be a part of this initiative where we kind of upgrade our knowledge, our existing knowledge, to help serve those who are affected by this flood. Uh, as skin is a visible thing, skin conditions are quite common in communities and they get more aggressive because of lack of hygiene and lack of spacing during flood affected times. Also, these floods bring with them a lot of, water, contaminated water, infections, and since people do not have access to hygiene measures, they tend to get affected from these things. So there are basically some pointers, some common conditions that people get affected in these cases. We will be discussing them on those headlines only. So can we move the slide? Yeah. Yeah. Okay. So cutting to the chase, most commonly, there are inflammatory skin conditions like eczema or contact dermatitis. And then there are infective skin conditions, which may be like bacterial skin infections and fungal skin infections. And there can be other miscellaneous skin diseases, such as allergic reactions to insect bites, because we know the water are harboring agents for a lot of insects, and psycho-emotionally aggravated primary skin diseases like psoriasis, atopic eczema. They also get aggravated during these conditions. We will be discussing each of them individually. So let's move on to the next slide. Yeah. Okay. So inflammatory contact dermatitis, mainly we had them as eczema. They will affect only those parts which are coming in contact with the irritant. Most of the irritants are usually caustic agents. They can be like strong acids or alkalis as we use in cleaning products, um, uh, soaps, detergents, even chronic exposure to water can lead to these kind of condition. So since they come only when we are in contact with them, so they will appear mostly in those exposed areas. So most common sites of appearance is usually hands or feet. And these are inflammatory conditions. So there is some amount of redness along with scaling. Scaling is exfoliation of the upper layers of the skin. And they are usually very chronic, long standing. They will not come with a short history of like maybe 2, 3 days it happened. It's not like that. They will say it gradually started. Initially, it was small, then it gradually started spreading from one finger to another finger to third finger. And they will also give you a history of like, I have to chronically, be in contact with cement or be in contact with dishwashing liquids or detergents. They will also say like I cannot, um, you know, uh, do my day-to-day activities without being exposed to water for prolonged periods. Also, in flood situations, people whose houses are completely submerged in water, they have to be in that water for prolonged periods of time. All this will lead to aggravation of these conditions. So, classical features here is like the lesions are usually not well defined. They will come in contact areas and they will be bilaterally symmetrical. eczema usually because people are doing work with both their hands and both their feet. So it's very uncommon to be unilateral. It's mostly bilateral. And it will start from a point where most contact happens. Like it will start from intertriginous areas because the irritant, whatsoever it may be, has longest time to stay there because upper parts and outer parts get washed frequently. So the agent does not stay in contact for long there. Once it starts, it will gradually spread towards other parts also. And most of these patients will come with history of application of one thing or the other, and which usually helps because most of the over-the-counter drugs given by pharmacists in India are steroids, and topical steroids do help these conditions. However, the basic problem here is damage of the skin barrier, which they do not take care of. So it happens again and again. So key pointers here would be like there will not be any well-defined margin of the condition. And since it's an inflammation, there will be redness. Sometimes if the inflammation is very intense, it can also lead to vesicles, fluid-filled lesions. And once the fluid-filled lesions break, it can show up as erosions or ulcers as well. Can we move the slide? Next slide, please.
Sir, I'm pressing it. I don't know why it's having little issue.
It's not moving. Yeah, okay. Yeah, so as we can
Is
see
it
in this
visible
picture,
now?
yeah, it's visible now. As you can see, these are downloaded pictures. I did not get time to kind of put my personal pictures here. So as we can see this in this image, there is diffuse lesion in both the feet, but there is no clear demarcation where the lesion starts exactly. And the top layer is kind of coming off in the form of scaling as well as darkened areas of peeling. And in the margin, we can see there is some amount of pustules, pus-like lesions. They are showing sign of activity. And the beginning of the lesion can be tracked towards the intertriginous area between the first and second toe. Similarly, in the second image, we can see a lot of papillopustules with diffuse arrangement and no clear demarcation. So this we can classify as eczematous disorders and treat with topical steroids. Please move the slide. Yeah. Yeah. So basic treatment for this would be like topical steroid combined with an antibiotic. So most commonly we should go for mid-potent steroids like mometasone combined with a topical antibiotic to take care of a secondary bacterial infection because the barrier is damaged and they are exposed to sewage water. There are high chances that it will get infected. So, mometasone combined with fusidic acid or fluticasone combined with mupirocin are the choices here. In cases of severe reactions, severe eczematous rashes, we can also go for clobetasol, which is a high steroid. However, I would not advise you to use clobetasol. Go for mometasone fusidic acid. It is available in a lot of brands. If you want like cheaper ones, you can get like Momet F or HH Fudy cream. They are available. And on top of the steroid, we have to also consider some amount of barrier repair. So for barrier repair, we have to go for a good quality moisturizer. However, in resource poor settings, getting hands to a good moisturizer is quite difficult. In that thing, we can see if we have liquid paraffin available. Also, we can use Vaseline, petroleum jelly, which is readily available. Coconut oil can also act as a good occlusive moisturizer in resource poor settings. Also, we have to take care of the itching because each scratch cycle is the inducing factor here because whenever the patient scratches, they will induce new injuries, which will lead to aggravation of the condition. So, taking care of the itching is very important. So, for that, we can add one oral antihistaminic. Levocetirizine is the antihistaminic of choice because it is um, uh, economical as well as having good efficacy. So, prescription would be like a liquid paraffin, mometasone fusidic acid combination cream, and levocetirizine. You give for 2 weeks, then reassess, and then if the inflammation is going down, you gradually taper down the steroid. Like if we are giving mometasone twice daily, then we will taper it down to once daily and once every alternate day, and gradually. Along with this, protection measures are of very high importance unless we take care of the thing that is causing the eczema, be it water, be it acid, alkali, or soap detergent, unless we stop the contact to these agents, we are not going to cure it. So we also have to advise them rehabilitation measures. Suppose if eczema is happening because I am working with my bare feet in a paddy field again and again, then I have to somehow get my hands onto gumboots, which help my feet get protected from those exposure. Suppose if I am getting eczema in my hands because I have to wash dishes all day, unless I use protective kitchen gloves while washing those dishes, it is not going to cure. No amount of medicine is going to cure my eczema. So these are the basic things how we are going to manage eczema. However, we also have to look for signs of infection because eczema, the skin is broken, and there are high chances that it will get secondarily infected by bacteria. So we also have to look for signs of infections. Signs of infections can be local. Look for warmth, increased redness, discharge of pus from the lesions. These are the local signs of infection, and you also have to look for systemic signs of infection. Systemic signs of infections would be like feeling of malaise, fever, rise in temperature, and sometimes if the infection is very severe, can also lead to like severe signs, which are not needed here. So if patient is showing signs of infection, then we may consider giving patient oral antibiotics for a period of 7 to 10 days to take care of that infection as well. Can we move to the next slide? Okay. Yeah. So our next heading is like bacterial infections. So exposure to this unhygienic conditions and people not having access to sanitation facilities can lead to a lot of bacterial infections as well. So the commonest bacterial infections can appear in children in the form of impetigo, which is a superficial infection of the skin. It can appear in two forms. Impetigo can be of bullous type, where you will get like fluid filled lesions, mostly in and around the face area, in and around the limbs, sometimes on the trunk as well. And it can also be of the non-bullous type, which is non-bullous impetigo. It appears as brown, honey-colored crusts, mainly on extensor parts, and around the face, nose and mouth. Um, These are in the children. In the adults, what we can see is folliculitis, which is usually the infection of the hair follicles. Because of damaged skin or scratching, sometimes the infection can enter through those follicles and start growing there. It will appear as raised bumps surrounding the opening of the hair. It usually happens in the scalp, wherever the hair bearing areas are. It can usually appear in your scalp, it can appear in your legs, it can appear in your hands, back. And when the infection is very severe, it usually, including the hair follicle, it can also inflame the surrounding area, which is called furuncle. Furuncles usually would need higher antibiotics, so need to be identified. And furuncles will be usually associated with pain and tenderness and sometimes systemic symptoms as well. Other than these infections, we can also have other forms of infections, which are like deeper infections of the skin. In the deeper infection, we can get erysipelas, which appears as a reddish patch, we can say. It is bright red in color. It moves. The infection is in the dermis. However, it has not crossed to the hypodermis. So it is still well demarcated. If the infection moves to the subcutaneous tissue, then we will call it cellulitis. And cellulitis will be an emergency infection and will need injectable antibiotics to treat. Can we move to the next slide? Yeah, so in this picture, as we can see, um, there is a diffuse plaque. When I say diffuse, we can see the margins in this lesion is not well defined. It is kind of merging with the surrounding area. And in the center, we can see a crust which is yellowish in color. So that is dried up pus, and some areas of erosions also we can see. And this area is surrounded by uh, bright red color erythema. So this is a sign of bacterial infection. In the second image, we can see a well demarcated um, patch um, with a central opening, which was maybe the point of entry of the infection. And this is bright red in color. We do not see any pustules or anything, but this is because the infection here is deeper than we see. This is erysipelas, and this one is we can call it impetigo, and the second image is erysipelas. The treatment for both of them would be like antibiotics. We can start with topical antibiotics. However, the severity, as we can see in this picture, would warrant oral antibiotic as well. Can we move? Yeah. In this picture, we can see certain uh, bumps in the leg as well as in the neck and axilla area. So here we can see um, the lesions are typically around the hair follicle, and they do not they show a whitish color, which is the pustule, and the redness here is very less. So this is a superficial folliculitis, which is um, commonly seen in children. And the most common treatment here would be like topical antibiotics for a week should usually help resolve these conditions. This will happen in resource poor settings. Also, if the humidity is quite high and the children sweat a lot, but the sweat does not get evaporated because of the high humidity. So it kind of um makes them predisposed to this kind of infections. Move the slide. Yeah. So baseline treatment for all the bacterial infections would depend on severity. So folliculitis, impetigo, um, these can be treated with topical antibiotics only. So the topical antibiotic of choice would be mupirocin, but mupirocin comes mainly in ointment form. So it should be reserved for localized infections. If the infections are widespread, then we can go for topical fusidic acid. It comes in cream form and can be applied for longer, larger body surface areas. And these days, we also have ozenoxacin creams and lotions, and they can be applied over a larger area as well. The benefit of ozenoxacin that it can be used once daily. Once daily application is sufficient. However, mupirocin and fusidic acid we have to apply 2 to 3 times a day. However, if the infections are more serious, more severe, and associated with systemic symptoms like fever and all, we should consider going to oral antibiotics. The oral antibiotics of choice is the penicillin group of drugs, mainly ampicillin, amoxicillin. Commonest one available everywhere is amoxicillin plus clavulanic acid combination. So that is the first line of treatment. We have to, for children, we have to give it according to their body weight, which comes around 15 mg per kg body weight. For adults, we use 625 mg 3 times a day for a period of 7 days. Um, in case patient is already on amoxicillin or you think the infection is more severe, we can also consider cephalosporins. Cephalosporins, usually we go for first generation cephalosporins. Cephalexin is fine. In cases of deeper infections like cellulitis, we have to switch to um, IV antibiotics, third generation cephalosporins. Um, However, if available, before starting antibiotic, we should always do a confirmation of the infection, doing a pus culture, uh, if it is available, because in case of growing antibiotic resistance, we do not want to use antibiotics unjudiciously. So, for most of the common bacterial skin infections, our example prescription should be amoxiclav, amoxicillin plus clavulanic acid, 625 milligrams, 3 times a day for 7 days, with a topical antibiotic like mupirocin ointment, which is available as T-Bact, B-Bact, C-Bact, twice daily application for 7 days. Along with this, we also have to advise them proper cleaning of the affected area. We can use diluted Dettol or Savlon for the cleaning purpose, or betadine to clean the area before application of this. And we should also make sure they have access to proper bathing and all. Can we make a move to the next slide? And the third is the commonest around here, which is the fungal infections. So fungal infections mainly appear in tropical areas because of high heat and high humidity. High heat and high humidity makes us sweat a lot, and that sweat also does not get evaporated. So it makes a nice breeding ground for fungus. It usually spreads from person to person. However, it can also spread from contaminated articles like contaminated clothes, contaminated towels, contaminated bed sheets, and sometimes it can also come from um, infected animals to humans. The main infections that we face on a day-to-day basis is tinea. Uh, Tinea can be divided into different types depending on the area involved. So tinea can be like tinea capitis if it involves the scalp and hairs. It can be tinea faciae if it involves the face, tinea barbae if it involves the bearded area. Other parts of the body, we call it tinea corporis. If it involves the groin area, we call it tinea cruris. If it involves the palms, we call it tinea manum. If it involves the feet, mainly the soles, we call it tinea pedis. Other fungal infection is candidiasis. So candidiasis is caused by Candida albicans. It usually affects the flexural areas, like the axilla, inframammary areas, groins. It can also cause infection of the nail folds. Also, it can infect the mucosal areas like oral candidiasis and genital candidiasis. The other form of fungal infection we see commonly is paronychia. So paronychia can be divided into two. It can be like acute paronychia. Acute paronychia is usually bacterially mediated, and chronic paronychia, which is a mix of bacterial as well as fungal infections. And the other common one we see out here is pityriasis versicolor. It is a superficial fungal infection, usually found in the children, appears as white or black patches, mainly on the neck, face, and chest, back, axilla, with a furfuraceous scaling. Like when you scratch, the scales easily come off. Let's move to the next slide. Yeah. So as we can see in this image, we have a well demarcated plaque. Plaque is a patch-like thing. So the differentiation here, usually the tinea lesions are very well demarcated with a central clearing. As we can see, the center is getting cleared and a raised margin with activity, signs of activity on the margin. The signs of activity can be erythema. The signs of activity can be pustules, papules, sometimes vesicles as well. And the entire lesion is showing mild scaling. The skin is coming off. So this is a classical picture of tinea corporis because it is on the random part of the body. Um, and uh, we have to differentiate it from other eczematous conditions by its morphology. However, most of the patients, when they come to you, they will have treated it to some extent with either topical antifungals, topical steroids. Steroids are a nuisance here because once you treat with topical steroids, the lesions becomes very imperceptible. The signs of inflammations go down, the margins kind of blend, and it's very difficult to catch. So you have to always take the history. History is very important here, the treatment history especially. And tinea usually comes in packages. Isolated localized tinea is very rare to find. So if you see one lesion and just treat that, the patient may be harboring similar lesions in their groin, which they may be kind of embarrassed to tell you about. So you have to ask specifically where all do you have the lesions. The patients might say like, this is the only lesion, I do not have any. Then you have to give them like leading questions. Do you have similar lesions in your groins? Similar lesions in your perianal area or gluteal cleft? Similar lesions in your axilla? Also, never forget to examine their nails because sometimes what happens, fungal infections in one part of the body is always associated with fungal infections, is sometimes associated with fungal infections in their nails. So if you see, I mean, erythematous plaque in one part of the body with a fungal infection nearby of the nail, and you are not sure whether this is eczema or fungal infection, you can take that clue from the nail and treat it as a fungal infection initially. Can we move to the next slide? Yeah, here we can see two forms of tinea pedis. So tinea pedis has multiple subtypes. Most common that we see in day-to-day life is the interdigital type, which usually starts from the web spaces, and the hyperkeratotic type, which usually appears as excessive keratotic plaques with scaling. Here we can see the excessive white scales that have appeared. along with a clear-cut margin, and the activity is highest in the margins, as we can make out from papules and pustules that are appearing in the margins. Uh, Also, like tinea lesions, it will be very difficult to differentiate from eczema or psoriasis. So, for resource poor settings, where you cannot, like, you can somehow get access to a microscope, the easiest way would be like to scrap the lesion, collect some scales, put 1 drop of potassium hydroxide, and then look it under a microscope. That will give you a basic identification of the fungal spores in the lesion that can be arranged somewhere. However, if it cannot be arranged, the other clues that will help you would be like unilateral lesions. Like eczema is usually bilateral. However, fungal infections do not appear like that. They are mostly unilateral. Can also happen bilaterally. Then you have to look for other sites as well. That will help you identify or differentiate from eczematous conditions. Also, when you are very confused, I would suggest give a antifungal trial for maybe 10 days and see if the lesion responds to only plain antifungals, because any lesion will respond to steroid, be it eczema, be it fungal infection. That will not help you differentiate whether it was either eczema or a fungal infection. So rather start with a topical antifungal. If you see some amount of response in a week, you can go ahead further with antifungal therapy. If you see no response, then you can consider your differential to be like eczematous condition. Can we move to the next slide? Yeah, so the baseline treatment for fungal infections would be like if the lesions are very localized, 1 or 2 lesions, we would start with only topical antifungals. The topical antifungal of choice here would be like luliconazole, uh, terbinafine. We can go for topical amorolfine, topical cycloperox, depending on the site of the lesion. However, for best option would be like luliconazole, applied twice daily on the rash for a period of 2 to 4 weeks. However, if there are multiple lesions, we would like to add on to that with oral support, oral antifungal. Oral antifungal of choice, in our case, would be like oral itraconazole, because these days a lot of fungus has become resistant to other antifungals. So oral itraconazole in a dose of 200 milligram once daily. Itraconazole has a lot of drug interactions, so it would be nice to take the drug history of the patient, whether they are on multiple medications. Um, Also, itraconazole is an enzyme inducer. It will increase liver enzymes transiently. So, patient's liver status needs to be assessed prior to starting itraconazole. So, it would be nice to take whether they are alcoholic or actively taking alcohol or not, like that. If possible, do a liver function test prior to starting itraconazole. Other drug choices would be like oral terbinafine, which is given in a dose of 250 milligram once daily. For children, we can give oral terbinafine if the child is less than 20 kg. It's given as 67.5 mg. The child is less than 40 kg, we give in a dose of 125 mg. If the child is more than 40 kg, we have to give 250 mg once daily. And for nail infections, we have other dosing regimens. For nail infections, we can go for oral fluconazole. Fluconazole has a longer half-life, so it can be given once a week treatment. So we can go for fluconazole, 150 milligram once a week, uh, or twice a week, and we can add topical antifungals like nail lacquer, which is available as cycloperox nail lacquer or amorolfine nail lacquer that we can give for nail infections. And yeah, can move to next slide. The other fungal infections that causes a nuisance here is candidiasis. Candidiasis is caused by Candida albicans. It usually appears in the intertriginous areas like axilla, submammary areas, groins. So it usually is different from other fungal infections because here the area gets macerated. The areas look oozy. They are wet, moist, and the margin is not uh, a smooth line like tinea infections. Here, the margins are very uh, frivolous. They are not in a single line. Also, here we can see some satellite lesions uh, in the margin because the fungus kind of moves like that. So they cause satellite lesions, and the margins can also show presence of pustules or papules like lesions. Uh, if they appear on genitals, they can also appear as fissures, like breaks in the skin. They can cause burning more than itching. Uh, in tinea, it was itching more than burning. Here, they may cause burning more than itching. That is an important clue. And also, here important is to check the immune status of the patient. Patients might be diabetic or having some other immunocompromised conditions. They are more prone to develop candida infections. Let's move to the next slide. Yeah, so for candida infection, the treatment of choice would be like topical antifungals. Clotrimazole is still sensitive. I mean, candidiasis is still sensitive to clotrimazole, so that is the treatment of choice. Topical clotrimazole cream to be applied twice daily. And if at all this infection is very severe, we can go with oral fluconazole, 150 milligram once a week, or oral itraconazole also we can give, 200 milligram once daily, for a couple of weeks. Let's move to the next. Yeah, paronychia, it is the infection of the nail fold. It can be like proximal nail fold or the lateral nail fold. So paronychia is usually considered acute, which is bacterial in origin. Here in this image, the second image, we can see the swelling, redness, oozing blood. This is acute paronychia. This is usually caused by bacterial infection. We have a lining in and around our nails, which is called cuticle. If that cuticle is broken, damaged, if we pick it, we bite it, then it kind of makes a new space for bacteria to enter there. And acute paronychia usually appears as a swelling, pain, tenderness. It can be associated with systemic fever, and it usually gives a short history, like maybe a week or 10 days. And for acute paronychia, the treatment would be like oral antibiotics and topical antibiotics. Oral antibiotics, as we already discussed, amoxicillin clavulanic acid will be the treatment of choice for a period of 7 days. However, in chronic paronychia, as we can see in the first picture, the swelling is diffuse. It is not very large. The erythema has come down, and there is some amount of scaling. And this happens because of chronic exposure to damaging substances, as we have in eczema. The cuticle unit kind of gets dysfunctional, leading to entry of this stuff. It can have like mixed infections, mixed fungal bacterial infections. So we have to treat it like that. Initial part we treat with antibiotics. Once the initial treatment is over, we can take them to a long-term antifungal therapy in the form of oral antifungals or fluconazole once a week, along with topical luliconazole or clotrimazole creams for longer period. Also, we have to take care of barrier repair here because chronic exposure will kind of aggravate this condition. So we have to give them proper gloves or advise them not to use water or detergent too much. Can we move to the next slide? Yeah. So as we already discussed, topical antifungal once a day, along with combination creams for a week. Maybe combination creams, they are widely available, but we do not use them anywhere else. Combination creams are only used in paronychia. So combination creams would have a steroid, antifungal, and anti bacterial agent. For example, like Betnovate GM will have betamethasone, gentamicin, and miconazole. So these combination creams can be given for 1 week or 10 days, and then we switch to only antifungals. So example prescription is mentioned here. Can we move to the next slide? Yeah. So the next condition is tinea versicolor or pityriasis versicolor. It is caused by a fungus, which is Malassezia furfur. This is mostly cosmetic concern, as it is not a deeper infection. So it can appear in two forms: hypopigmented variant, which appears as white scaly patches, mostly in the neck, face, axilla, back. The scales here are very loosely adherent. So if we scratch the surface, the scales will come out very easily. So that is called like scratch sign. Here we do that scratching procedure and we can see the scales increasing. Uh, it is a very common condition to find in children and young adults, and the treatment is quite simple here. We go for topical selenium sulfide lotions, but they are not widely available in India. So we can go for topical ketoconazole 2% lotions or washes to be applied half an hour before bathing on the affected area for a period of 1 month. Can we move to the next slide? Along with topicals, if we feel the need of oral medication, we can give oral antifungal, fluconazole, 400 milligram, once a week or once every 2 weeks is fine. So the example prescription here would be like oral fluconazole, 400 milligram stat dose, along with topical ketoconazole lotion to be applied twice daily for a period of 1 month. Move to the next slide, please. Yeah. So the other common infection that presents in very crowded places is scabies. It is a very common infection, usually seen in children and adults that come in contact with those children. It is caused by a mite that we call like Sarcoptes scabii, var hominis. It presents as papules mainly in the hands. It can also present in other parts of the body. So the lesions typically here will not affect face and scalp because the oil in the face and scalp is kind of scabicidal. So the mites do not venture to the upper parts. They tend to stay below and they will lay eggs. Wherever they will lay eggs, there a bump will appear. The bump can sometimes turn vesicular as well, and we can typically see those nits in the web spaces of our hands. Um, Large nodules can be present in the genitals, in the penis vulva. We can see the mite burrows in the hands. Sometimes we have to strip the patient to see those lesions, to find those lesions if we see a suspicious lesion anywhere. The leading clues here would be like a family member is also infected with the same condition. The itching is typically more at night because the at night the mite starts roaming, so the itching kind of increases. Also, the patient as they kind of go to sleep, their other thoughts are not coming, the itching also aggravates. And the history here is quite short. It is usually less than a month. So these are the clues that help us diagnose scabies. Scabies, as it is a community disease, needs to be treated at mass. So treatment of one individual is not enough. Even if there are no signs in the family contacts, we have to treat the contacts everybody. The treatment is quite simple. We use a scabicidal, which is permethrin 5% lotion, to be applied on clean skin and rubbed it in at night, and it has to be kept for 12 hours and washed the following morning. And along with washing the lotion, we also have to wash all the contacted fomites, the clothes used, the bed sheet, the blanket. Everything needs to be washed in hot water and dried in proper sunlight. One application usually kills 99% of the mites, so two applications are necessary at a gap of 1 week. And along with that, we can also add oral antihistamine like levocetirizine for control of itching. And if the genitals have large nodular lesions, we can also add one topical steroid antibiotic cream, which is usually mometasone combined with fusidic acid, only on those large nodular lesions to kind of alleviate the itching. It has no other function. Also, if we have to kind of give a mass treatment for villages, we can consider tablet ivermectin. That has to be taken, ivermectin tablet, 12 milligram, taken once a week for 2 weeks. And it is kind of easy to administer. We can give to a large number of people, considering resource poor settings. Can we move to the next slide? Yeah, so that ends the presentation that I made. Now, can we take up the images shared by you so that we can discuss that as well?
Hello.
Hello.
Uh, I don't think we have got any images. I just have a few comments.
Okay. I can see one of the comments that gamma benzene and levocetirizine with us. Okay, so gamma
Yeah.
benzene is also effective in scabies. So we can use it to treat scabies. However, the efficacy is not at par with permethrin. So gamma benzene also we can apply once a week um for 2 weeks. Levocetirizine twice daily is not necessary, as levocetirizine is a long-acting drug. We can give it once
24 hours.
daily. Yeah, 24 hours. We can give it once daily. Also, the disinfection of fomites is very important. Ivermectin is like not necessary. However, the world has moved from gamma benzene because it is a toxic molecule. So I would consider kind of moving to permethrin, which is better.
Only a few comments. I'm a professor from Bharati Medical College, DVL, Sangli, and
Hello, sir.
we had severe floods around 7 years ago. So we have had lot of experience, particularly regarding floods. And as you
Oh,
said, contact allergies also were very common with us, and particularly in seniors. Scabies
mm,
was
yes,
rampant. One thing that we
yes.
found was leptospirosis. It was very common because the water stayed for around 14 days or something. So
Oh,
leptospirosis, we got a lot of cases. For all infections, cefadroxil was available. It was economical, and nowadays mupiracin also comes in a cream form. So though a
yes.
little costlier than
Yes.
sulfuric acid, that
Mm,
works better, particularly for patients where it is necessary. Tinea
Yes.
incognito, particularly in flood times, we did not find very commonly because it's a short period. And for tinea incognito to come into effect, maybe it needs around a couple of weeks of steroid contact. So that was not very common. And the most common that we found was candidal intertrigo of feet for obvious reasons.
Yes. Mm.
But for nails, we made a rule to use 400 per week without any change.
Side effects.
And
Yeah. Mm.
clotrimazole or miconazole is effective, is very economical. So if the lesions are limited or small, we could do with that. Otherwise, itraconazole and something from the other groups like cyclopyrox and amorolfine work very well.
Mm.
But you did a wonderful job. You had a limited time, but you
Thank you, sir.
covered most of the things very nicely. Thank you. Thank you.
Thank you, sir. Mm.
I would like
Yes.
to ask a
Any?
question.
Yes.
Uh, for, for tinea pedis, we have oral fluconazole drug. So,
Yeah.
how should we use for it?
Uh, Oral fluconazole for tinea pedis.
Yes, yes.
Yeah, we can use oral fluconazole for tinea pedis. However, in my practical experience, if we ever resort to oral fluconazole, we'll have to give it on a daily dose basis. So the daily dose of fluconazole is usually 50 milligram daily. So that is not readily available. So you can go for 150 milligram every alternate day. That would be fine. And it would, I would say you would reassess at 1 month. And if it is getting better, you can stop the oral one and switch to topical. I mean, continue the topical.
Okay, okay. Thank you.
Welcome.
We are using currently for tinea pedis, we were giving oral flu. I think we should change this as you suggested. Thank you so much for this.
Yeah.
Sir, is it
Okay.
visible?
Oh, what?
Oh,
No, it's not
okay.
visible. Can only see the logo. Yeah. Okay. I can see the image. Yeah, so as we can see in this image, all I can see is in this image is a form of chronic eczema because the skin has become thicker and there is pigmentation. The erythema has subsided. The thickening is because of the constant scratching. So the history here would be very important, whether it is unilateral or bilateral, happening in both hands or one hand. Um, the duration of the disease is very important here. Whether it is looking at the lesion, I can say it's not happened like overnight or a period of week or 2 weeks. It is at least like 3 months old. And the third important history would be like exposure to water and detergents. All this would help us kind of pinpoint our diagnosis to eczema. However, if it's unilateral and happening acutely, I would like to do a fungal mount or give a antifungal trial. If this is not there, I would treat it as an eczema with topical steroid antibiotics. We can see the nail here that also looks like having some form of fungal infection going on. So it can be considered like a mixed infection. So we also have to treat that fungal infection with oral antifungal as well. So that can give us a clue. Okay. Um, this image, I can see varicose veins here. Uh, maybe you were trying to focus on that leg. Yeah, leg. foot. So here we can see the scaling and diffuse hyperkeratosis of the entire feet part, which seems to have started in that intertriginous area. Um, Again, here I would like to see the other feet as well. For me, it looks more eczematous than fungal, but however, we cannot rule out secondary fungal infection of the intertriginous area here as well. So my treatment would be like, giving an antifungal trial just to rule out fungal infection here, antifungal trial for a couple of weeks. And if not respond, then we move to like treatment for the eczema part as well. Move to the next image. Yeah. Here we can see a child with vesicular eruptions, which have kind of ruptured, left behind scaling. So this can be treated as a form of impetigo, non-bullous, definitely. So we can treat him with topical antibiotics. And if the lesions are more severe, we have to add like oral antibiotics as well. Yeah, move to the next image. Yeah, here we can see a well-defined plaque with kind of raised margins. Um, this is thigh. Yeah. So this is a lesion which looks more in favor of a fungal infection. So I would say treat with antifungal therapy, oral itraconazole along with topical luliconazole. Move to the next image. Okay, I cannot make out the rash here. Maybe near the middle medial canthus, there is a scaly plaque. So that can be semi-treated tinea fasciae. So I would say because the plaque is not well demarcated, it is just some scaling visible. So I should say if it's unilateral, treat it with a antifungal first before moving on to steroid or anything at all if needed. First, give an antifungal trial here. Move to the next image. Yeah, so this image you can see a lot of hyperpigmentation, color change is going on. So this is definitely not an acute thing. Uh, so this looks like an eczematous condition because the margins are not very obvious, inconspicuous, and there is hyperkeratosis, hyperpigmentation, and diffuse margins. Classical for eczematous lesions, we call it lichen simplex chronicus. So the choice of treatment here would be a topical steroid and barrier repair moisturizer along with topical antihistamines. Also, avoid scratching at all costs. Move to the next image. I think this is the first image we already discussed. Yeah, this image is also discussed. Yeah, this in particular child, I think we discussed already. Same image. Yeah, so this image um, is very difficult to say. Looks like a diffuse scaling along with hyperkeratosis, which is thickening of the skin. As we can see, it is also along with the knee portion, it is also going on in the feet as well. So it can be uh, eczema, which is kind of growing upwards, or it can be a fungal infection as well. Very difficult to say from the images here. KOH mount would be of prime importance. Also, look for other places. Like if this much fungal infection is going on, the patient will have like 90% chances they will also have an infection in the groin, tinea cruris. A tinea cruris here would help us kind of start antifungal treatment straight away. However, with so much uh, widespread lesions and absence of any other fungal lesions anywhere else on the body, it can be treated with as an eczema or contact dermatitis. Please move. Yeah, so here also we can see hyperpigmentation, ill-defined margins, no erythema. So we have to treat it as a contact dermatitis with steroids and emollients and antihistaminics. This typically happens along the margins where the sandals or the shoes kind of come in contact with the feet. Move to the next image. So here we can see only one small lesion. Yeah. With mild scaling, mild erythema, and maybe another small erythematous rash above it. Yeah, so it does not have a well-defined margin unless something has been applied to it. We would treat as an eczema or contact dermatitis. Can be like photodermatitis as well because it is going on photo-exposed areas. So I would like to treat it with topical steroids. Yeah. Next image.
Uh, Sir Srinidhi Datar has a doubt. I would
Yeah.
request him to unmute and ask.
Can you scroll to the previous image with a scaly lesion on the knee? So my question was because of the presence of scaly lesion in the anterior aspect below knee, could it be psoriasis also one of the differentials?
Uh, my first differential will not be psoriasis here because psoriasis has three classical symptoms, erythema, scaling, and induration. So we can see scaling, but there is no erythema, no induration. Induration is something you can palpate. When your eyes are closed, you will feel it. Like this mole on my nose, if I feel it, I can feel it. That is induration. So the induration component is completely missing here. However, long-term treated psoriasis would would come out like can manifest like this, but there with the absence of raised plaques, it is highly unlikely to be psoriasis. Yeah, so this lesion we can see like hyperpigmented uh, patches in a exposed area. I think that's leg of a patient. Yeah. So this can be like insect bite reactions. We also call call it as papular urticaria. Happens in allergic individuals whenever a mosquito bites, instead of just a small wheal and going away, they kind of scratch it, and it becomes hyperpigmented like this. So these kind of patients would need like topical steroid antibiotics along with increase the coverage. Yeah, they cannot wear, short clothes because insects will come and bite and will cause this allergy again and again. And also we can go for like mosquito control measures or insect control measures in the form of Odomos screens if available.
Actually, I have seen this in chronic in conditions like CKD and diabetes also. Is it even
Yes.
diabetes dermopathy?
Yeah. So they are different. I think this is a child, I guess. But in CKD, yeah, chronic folliculitis can happen in CKD, definitely, because of constantly raised urea. And diabetic dermopathy, yeah, can also happen in diabetic dermopathy because of high advanced glycosylation products. The skin becomes quite dry. So in CKD, we have to kind of give emollients, moisturizers. In diabetic dermopathy, we have to give high emollients with urea along with topical steroid antibiotics are can be given in all these three conditions in papillary urticaria as well, in diabetic dermopathy as well, and in CKD patients with skin conditions as well. Yeah, so in this image, we can see some scaly lesions in the sole of the patient, and these are just peeling off without any erythema or this. So we can say this is not eczema because there is no erythema and all. This looks like a form of superficial bacterial infection caused by species of Corynebacteria. So topical antibiotics here would be like the treatment of choice, can happen in chronically submerged patients, like chronic exposure to water. This kind of superficial corynebacterial skin infections can happen. Topical mupirocin or clindamycin is the drug of choice here.
It looks like pitted keratolysis. Yeah.
Not, yeah, not pitted yet. Not pitted
Mm.
yet. May go to pitted soon, yeah.
Keratolysis.
Yeah, so in this image, we can see um more or less ill-defined plaque, erythematous plaque with scaling. So as you can see from the picture, it will be like palpable. We can feel it. However, the classical margins of a fungal infection and with a central clearing are lacking here. So it is difficult to label as a fungal infection unless we have a history of treatment, like whether the patient did treat or something. Um, from the picture, maybe it is psoriatic or eczematous. Yeah, so in this image, we can see a lot of hypopigmentation and scaling. So the color is kind of fading along with the lesions have started in the fingers and are kind of migrating upwards. So we can say this is maybe eczema, but definitely not a fungal infection because we do not see a clear-cut margin. Again, the treatment history would be important. And since it is mostly on the dorsal part of the hands, we also have to kind of consider the photo component of it, whether patient is undergoing excessive sun exposure or things like that. So I would personally treat it as an eczema and also maybe ask the patient to do some photo protection. Um, um, yeah, so it is a lower back showing some hyperpigmented patches and maybe one old heel scar. So the history here would be like very important. Does the patient have itching or stuff like that, or it is just a hyperpigmentation? Uh, yeah, but definitely does not look fungal because there is no margins or anything like that. So maybe frictional dermatosis or maybe some form of eczema can be here. So the thing here is the patient should stop scratching if they are scratching this because the scratching is leading to hyperkeratosis and pigmentation and barrier damage. So topical moisturizers and maybe topical steroids are the way to go here.
Sir, Ankita has raised her hand.
Yeah,
Please speak up, Ankita.
Hello,
yeah.
I'm Nick.
Hi.
So, this was a young boy. So eczema can be presented in
Mm.
young age also.
Yes, depends if suppose a child has a defective barrier. So atopic eczema usually presents in young age only because they have a defective barrier. They cannot retain the amount of moisture that is supposed to be there. So their skin becomes dry very fast. As the skin dries out very fast, it becomes susceptible to a lot of allergens, and scratching can kind of further deteriorate that barrier, leading to this kind of rashes. So here, what I would like to know whether any similar lesions are there in other parts of the body. Do they consider their skin quite dry? Any constant scratching history is there or not?
I don't remember that case. He just complain of
Hmm.
itching there.
Yeah, so yeah, we can kind of treat it as an eczema only. Quite unlikely to be a fungal infection.
Thank you.
Welcome. Yeah, so in this image, we can see like two swellings in the superior portion and one subsiding swelling. In the lower portion, there is a ill-defined plaque with swelling going on. So here also the history is quite important. How long the patient has been suffering from this. The lesions look lichenified. They are not very acute. Uh, so we can treat it like lichen simplex because of constant scratching. The lesions have become hyperpigmented as well as hyperkeratotic. So very less likely to be fungal infection. Should treat with topical corticosteroids along with barrier repair moisturizer and antihistamines. Yeah, so this is a very good image showing multiple things. As we can see, uh, something is starting in that intertriginous area and it's progressively going upwards. And if we see, there is some amount of well demarcated margin which is kind of going upwards. Also, if we notice the nails, multiple nails have like thickened. Some of the nails have changed color to black. So this is a quite likely case of tinea pedis interdigital variant along with onychomycosis, which is the infection of the nail plate and nail bed as well. So the patient would benefit from oral antifungal therapy along with topical antifungal for the skin, along with antifungal nail lacquers for the nails. Also have to like kind of reduce water exposure, detergent exposure. Yeah. So in this image, we can see the nail plate is slightly lifted from the nail bed and some amount of black things getting deposited underneath. So we can definitely suspect here something is growing underneath that, most likely to be a fungus. Um, how many number of nails involved is important here. Also, we have to look for any skin lesions present. Uh, Not likely to be a psoriatic nail change. So to be treated like onychomycosis. However, it looks like a very early form of onychomycosis. Yeah, so here we can see nails which are discolored along with blackening of the nail folds. However, we do not see any separation of the nail plate from the nail bed. So this can happen in a chronic paronychia because of eczematous conditions. However, the amount of fungal growth here is quite less. So we have to treat it like a paronychia with mixed infection. So oral fluconazole maybe once a week, along with topical combination cream with antifungal and antibacterial agents in the nail folds twice a day for maybe a month, along with avoidance of the agents which are triggering this. Maybe the patient works in betel nut or something, or too much detergent work. Yeah. So in this image, we can see plaque, which is kind of scaly, hyperkeratotic, but the margins are not well defined, well demarcated. So we treat it as eczema, not a fungal infection. This image is a little bit difficult. As we can see, something is starting in the intertriginous areas and is growing outwards. However, there is no well-defined margins. So the history would be very important here, whether it's unilateral or bilateral. The duration of the disease, how many days has it been there? Whether the patient has come in contact with a caustic agent. Yeah, but for treatment's sake, I cannot completely rule out fungal infection just looking at it. So maybe a trial of antifungal for a week, and if no response, treat it as eczema. Yeah, so the image is very, the angle is quite bad here. But however, it does look like tinea corporis. So treat like tinea corporis. Maybe like semi-treated or steroid modified. Yeah, because the margins are kind of mingling along with the surroundings. Yeah, move. Yeah. Okay. Here we can see hyperkeratotic patch on the dorsum of the hand, along with a lot of hyperpigmentation and scaling. So um, this is most likely to be some form of contact dermatitis. So treated with topical corticosteroid and emollients, moisturizers. Yeah, so this is whitish plaque in the uh, interdigital space, quite likely to be a mixed infection. So, to be treated with antifungal therapy, oral fluconazole and topical antifungal agents, and avoid water exposure. And also, if possible, keep that area open using a cotton wedge in between, because occlusion will kind of aggravate the infection. Okay. Yeah, so here we can see one lesion coming around the hair follicle. This is quite likely folliculitis. So treat with topical antibiotics and emollients. If needed, we can also give oral antibiotics. Yeah, treat it like folliculitis.
Uh, the images are finished. If
Over, yeah, okay.
anyone is
Any
having
questions?
doubts, yeah,
Yeah.
we can continue the video.
I
The
think,
last image is showing
ah,
multiple folliculitis. So
yeah.
this can be happen too.
Yes, yes. In chronic folliculitis of leg, usually the lesions are multiple only.
So we have addressed this doubt, no? We have only gamma benzene and levocetirizine with us.
Yes, yes, yes. We have addressed the doubt.
Okay. So uh, if you if you want to share any practical challenges and regarding any doubts for medicine,
Yeah.
we can continue the conversation, and I can then think to close
Sir,
the PDF.
Yeah.
hello.
Yeah, Srinidhi. Yeah.
Sir, could we, yeah, I don't know if it was already discussed. I joined in a late, but could we discuss the preventive aspects of, let us say, fungal infection or development of infective skin lesions, especially in the context of floods, and general
E-
skin care that the people must follow to prevent lesions. Also, about all these medication, they will need long duration treatment at times. So, how can we keep a follow up of these patients if possible, because this antifungals it sometimes it gets prolonged to 1 month or 2 months as well.
Yes. So, the best way to prevent is to keep the skin dry as much as possible because moisture is the primary driver of the infection. And sharing items should be avoided at all costs. So, like no sharing of clothes, no sharing of towels, no sharing of soaps. If possible, give them economical body wash. Body wash is good choice because sharing does not happen there. Secondly, washing intimate clothes in hot water is a good option because hot water kind of uh, cleanses the garment nicely. So the inner garment should be kind of washed in hot water. Upwards of like 60 degrees centigrade is fine. And yeah, and in cases of like excessive sweating, they can use any powder, be it Dermicul, Nycil, whatever is available. Wherever the sweating is happening more, like in axilla or groin areas where they sweat a lot, they can use dusting powder to keep the area dry. And fourthly, avoid exposure to water. I mean, it's a difficult ask when you are in a flood affected area to avoid exposure to water, but avoiding exposure to water is kind of important. These are the basic things. Other than that, some general things would be like, taking good care of your diet because immunity is important for fungal infections. Diet, taking good care of your sleep is a very important thing, kind of to not challenge your immunity so that your body can fight off like milder fungal infections. And coming to the follow-up aspect, we should ideally follow them up every 2 weeks to see whether the lesions are increasing or decreasing. Yeah, long-term follow-up is necessary, and ideally, the treatment should be like minimum of 2 weeks beyond the clinical symptoms because subclinical fungal infections are quite often the reason of reoccurrence of lesions. So, beyond the clinical resolution, a period of 2 weeks of treatment is necessary for complete cure of the disease. So, follow up the patient every 2 weeks for at least 4 visits.
Thank you so much, sir. I can see some people who are already working in Assam right now, like Nick and all. My question to them is,
Yeah.
are they seeing patients of leprosy, like hypopigmented patches, newly diagnosed, or the ones who are on treatment are not receiving the regular supply of drugs, or the patients who have developing lepra reactions? What is the status of leprosy in the area that you are practicing?
Yeah, I am practicing and I am seeing new patients. So like maybe um, one patient every couple of months. So the status of new patients coming up is like not going down according to me.
Sir, are they getting medicines from government supply, or are they developing any complications at all?
So leprosy has inherent lepra reactions, so that will happen whether they take medicines or not. About the government supply, it is quite extensive. The packages that are available, only thing is like the access to them is kind of difficult, and the patients, because of the stigma associated with this disease, tend not to go to a government institute because going to a government institute means like regular health visit to their home, which means the surrounding area starts to know whether this patient is getting leprosy treatment. And that stigma kind of, hampers them from seeking government treatment. But I would say the government does provide medicines if they can uh, take.
Thank you, sir.
Welcome. Okay.
So, any more doubts? Uh, if there aren't any, uh, we can come to close the meeting. Uh, Thank you, sir, again.
Yeah.
It was an extensive discussion, and I hope uh, these discussions and the PDFs might be helpful for everyone. Uh, so, have a good night and
Yeah.
thanks again.
Yeah. Thank you everyone for your patience hearing. I was happy to be a part of this initiative. Let me know if I can be of any help in future. Good night. Okay.